showing some TLC to your HEART. Smarter Heart University and Dr. Scott on AM 970, The Apple.
We're back on your Smarter Heart University. Dr. Patel, are you back on?
Yes, I'm right here.
Thank God. Callers, listeners, please forgive me. We definitely thought we had another caller on, and I was trying to put 3 people on so that Dr. Patel could answer some questions. I don't know. Dave, are you still on too? No, we don't have Dave. I'm afraid to even touch this. Anyhow, the answer to the last question was, what is the best diet for an atrial fibrillation patient to be on? Atkins, Pritikin, or Mediterranean? What do you think, Dr. Patel?
I think that the Mediterranean diet is the best diet for an atrial fibrillation patient. Again, there's a caveat with no real regimented placebo-controlled trial.
Oh, we lost him again. Yes, sorry, we lost Dr. Patel again. My apologies. Hopefully we'll get him again. The Mediterranean diet with its reverse pyramid of protein on the top, and then fruits, nuts, and vegetables in the middle, and then all the way down at the bottom of the carbohydrates, along with drinking more wine and less caffeine, seems to be the best diet in terms of reducing the triggers for atrial fibrillation. It's really a factor of looking at all the things. We talked about alcohol. We talked about diet now. We talked about the gender differences. There's so many different factors, as I said, inside and out, that really play into how much atrial fibrillation you're going to get and what we need to do with it. Now, hopefully Dr. Patel will call us back again. I think he is. Hello? Dr. Patel?
Yes.
Okay, I'm sorry. We were talking about the Mediterranean diet, and we were talking about factors that trigger atrial fibrillation. You were talking about some of the direct comparisons and studies that have been done.
Right. I was mentioning that with limited data available, the bottom line in my perspective is, I see patients with AFib who already have AFib. From a prevention perspective, from a more community-based perspective, I strongly believe the best diet, the diet that will allow a patient to lose weight, be physically fit, be able to approach a normal BMI range, is probably the best diet for them when you look at it, a community-based approach. But then when you start to tease out the differences, probably a Mediterranean-based diet is the best diet for a patient with atrial fibrillation, that with limited data available.
Were you surprised at data that said that obese people actually have less atrial fibrillation? It was very interesting. Yeah.
I was surprised by that data. What we know about AFib, and I often counsel my patients who have what we call low atrial fibrillation, and I assume that's a large population of our listeners as well, is that patients who otherwise are healthy from a cardiac perspective, is that the heart doesn't like being big, and that's what we know from really scientific studies, is that even in tall patients, AFib is very common, even it is a higher incidence of AFib in runners, because these are statistically and epidemiologically, these are taller people. These are people that are skinnier, that are fit, and that certainly does not have a role in the causality. It may be something to do with the size, and that's why we also were previously predicted that even larger obese patients should have AFib as well, but that hasn't necessarily panned the case. But we know that size has something to do with it because certainly the height has and running has definitely been related to AFib.
Sure. Now, in our last 5 minutes, I want to talk about the future. The Coumadin no more craze. Also, the newer antiarrhythmic drugs. Real brief, newer drugs for to abort the rhythm as well as suppress the rhythm are on the horizon. They're said to be more efficacious and less toxic. The newest one, of course, is dronedarone or Moltac, which replaces the old amiodarone. Basically, what I have learned is, and based on the studies, it's not as effective, but it's better tolerated and does have what we call evidence studies. You want to make a comment on that?
No, absolutely. Dronedarone has had or otherwise known as Moltac, has a lot of press and a lot of clinical data supporting it. It is, we both know it's a newer drug, so it's prone to the suspicions as we always have with newer drugs. So we don't have the same support as the other drugs we've been using for 15, 20 years. However, it does not have a lot of the toxicities that its sister or cousin amiodarone does, but clinically we also are finding that it is far inferior from an efficacious perspective. And from clinical practice, which often, and this is what I mean by having a newer drug, clinical practice, it's turning out to be more as a drug similar to flecainide or propafenone that we use rather than amiodarone, but still has good things, has a great clinical utility. You don't have to monitor, et cetera. So it's a great option for patients without congestive heart failure.
So I promised our patients, Coumadin no more, about what's on the horizon. The newer anti-clot medications.
Sure.
We don't have to check the level we call an INR, and it lower bleeding risks and more efficacious, more effective at preventing a stroke than Coumadin. And the two that seem to be the front runners at this point is dabigatran and betrixaban. Can you comment on those?
Yes. There are two. Without getting too scientific, there are two forms of what we call thrombin inhibitor. There's one form of thrombin inhibitors, which is dabigatran, and then factor 10A, which is a clotting factor inhibitor. There are three of those drugs that are actually in phase 3 trials. Now, the utility of these drugs are that they, as you mentioned, there's no monitoring. They're quick to onset within hours, and they are quick to wear off within 11 to 12 hours as well. There is a half-life. There is easily titratable for patients going for other procedures. You don't have to worry about higher risks of bleeding complications, which has always been the bugaboo with Coumadin. So it would make prevention of strokes a lot safer with these drugs because you don't have the excess risk of bleeding. Now, the
betrixaban, I just want to interrupt you for a second, Dr. Patel. The betrixaban seems like it's once daily as opposed to the dabigatran, which is twice daily. And the important point is that it may come along with an antidote to reverse the bleeding if you need a surgery or if someone's coming in and having the active bleeding. I think that's the big point. I just want to do some concluding points, and then maybe we have a couple extra seconds we can talk to you if you'll just hang on. Sure. Number one, about atrial fibrillation, we're seeing more of it as people are living longer. Number two, most of it comes from preventable cardiac illnesses like high blood pressure, coronary disease, and heart failure. Number three, controlling the heart rate or converting your rhythm they're both equally important, and each should be chosen based on your individual characteristics, and a guy like Dr. Patel would be the person to really help you with that. The risk of a stroke is high, 2% in the general population, and it can go a lot higher in the elderly. Warfarin or Coumadin reduces this risk, but is underprescribed and underutilized. Newer drugs are quickly being studied to replace warfarin therapy. Thanks to our guest, Dr. Ashish Patel, electrophysiologist at Jersey Shore University Medical Center, and Dave Berger on the Atrial Fib support line. Next week, men and women aren't from Mars and Venus. They're from different universes altogether. Women and heart disease. Tune in next week on your Smarter Heart University. Have a good week, and remember, friends, get to it before it gets to you.